You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello and welcome to episode 22 of the Geriatric Pharmacy Focus, and today is all about pharmacist's role in hospice care. And today with me is Carrie Krebs. She is the Director of Clinical Services at Pharmacy Care Associates in Alabama. We met at the American Society of Consultant Pharmacists meeting a couple years ago, not last year, but I believe it was the conference before. We ended up at the same table at a case studies discussion and immediately hit it off and talked about deprescribing. And Carrie also has a passion for deprescribing. She loves our older adults. She's a preceptor and just a passion for appropriate medication use in our older adults. And so I'm so thankful to have her here. So Carrie, welcome. And if you can, maybe just tell us a little bit about yourself.
Well, hello. Thank you for having me. It's such an honor to be here. When I first met you, I remember telling you I felt like I was getting to meet like a pharmacy rock star. So it was very exciting. And so it's exciting to be here today, too. I've been a consultant pharmacist since 2006. So I'm coming up on 20 years in the business. And I've been a pharmacist for I'm going to date myself. I have been a pharmacist since 2002. So I did about 4 years I did my time in retail and decided that was not going to be the long-term life for me. And so I came into long-term care and absolutely love it. So this is a wonderful area to practice in. I love it.
Oh, it's so good to hear. You're good at it, and you certainly don't look like you've been practicing that long. So kudos to you. So as far as hospice goes, the first question I have for you is, what do you see as the pharmacist's role in hospice care?
Well, we've got a bunch of different pharmacists down through the chain of everything that gets done in long-term care, but obviously we're responsible for dispensing the medications and making those available to the patients in our long-term care facilities in a timely manner. And at the same time, we're assessing the drug interactions and allergies when these new medications for hospice care are added on. And then there's also the possibility of deprescribing of other medications that are currently on board when we start the medications for hospice care. We may not immediately do it, but at least it's on our radar of, hey, we may eventually want to taper off of some of the medications that we're on as we start to use the hospice comfort measure type medications.
Yeah, I think pharmacists play such a big role, not only in the dispensing and getting medications to the patient in a timely manner, but also assessing those allergies, what pain medications might work the best for a patient. What do we do if they're agitated or shortness of breath, or just all the different things that come with hospice care. And what I did want to know is there regulations for hospice care like there is the state operations manual for skilled nursing facilities?
So the state operations manual does not carve out a separate set of regulations for hospice patients or for hospice care. But what they do is they basically overlay hospice-specific requirements on top of the standard nursing home regulations. So the standard nursing home regulations apply in the long-term care setting. But then on top of that, if you were going to bring hospice into the mix as well, there are some requirements that have to be included for hospice care, such as the coordination of care between the hospice agency and the facility to make sure all bases are covered. And then the contract is required with a hospice agency. So the facility has to have a written agreement with the hospice provider outlining the services that the hospice provider provides to the patient, and then they delegate out the responsibilities accordingly. So I can tell you as a practitioner, I've never actually seen any of these documents. I've never seen the contract. I know that they exist and they have to get signed before hospice care can begin on a patient, but it's not something that's typically in the medical chart. It's just a document that's kept on file. But both the hospice and the facility are responsible for shared care planning. And of course, that's such a big thing with, CMS and our survey teams and things like that. So the state operations manual really isn't great about differentiating between a patient with, say, like a rehab potential, like a knee replacement or a hip replacement patient that's there to get better and go home, compared to a hospice or palliative care patient. The same rules apply, but there are some extra responsibilities expected when a patient is placed on hospice.
The only contracts I've seen when a patient is placed on hospice, or the only documentation I typically see, is, the list of medications, what hospice is going to cover, what the patient is responsible for covering. And so I think working in the pharmacy, that's the documentation we see. Of course, we need to know, like, who's paying for this morphine, who's paying for, the lorazepam, is it hospice, is it the patient? And so that's helpful documentation to see. But yeah, that's all I've ever seen too when it comes to contracts. And so there is that layer of, yes, the hospice patients, we still have to abide by all the CMS regulations. Right. And then on top of it, hospice regulations also need to be followed. And it does seem like, speaking of the role of the pharmacist, I do catch a lot of open-ended PRN, lorazepam, haloperidols that need those end dates. And that does seem to be a struggle for me when it comes to hospice getting those end dates.
And I will say, that's always been a source of contention for me, because we know that the regulations say that if you're on a PRN psychoactive medication, it needs a 14-day stop date and you have to rewrite it every 14 days. And I've always said, when I explain this to my students, when I'm explaining to them the regulations, because of course students have no background in some of these rules, I explain to them, I will fight to my death. That is a hill I will die on to protect my facility should a surveyor get upset with us for having a PRN on a hospice resident. So I explained to them kind of why it looks this way and why that rule is there, which I do understand and respect. But I have never had a surveyor question a hospice patient that has an open-ended PRN. I think it's coming down the road. It probably will happen at some point in time, but so far it has not been an issue. I do wish that our regulations would sort of carve out some exceptions for hospice, but I think it's like an unspoken rule that it's okay if it's hospice, but in other circumstances, it's not okay. But it is not written down anywhere.
Yeah. I mean, when you look at the state operations manual, they leave 0 exceptions in there. But I agree, it would be so nice if they carved out exceptions for our hospice patients, for sure.
I agree.
So what are some of the more commonly used medications used in hospice for both those pain and non-pain symptoms?
So for the non-pain type circumstances like anxiety and shortness of breath, a benzodiazepine is common. And the most common one I see in hospice circumstances is liquid Ativan, or Ativan Intensol, is I think its brand name. And sometimes we call that air hunger, where the respirations slow down, and they slow down significantly. And then after an extended amount of time without breath, the patient takes a big, deep breath that can be kind of loud and make noise. And it sounds like they're struggling to get oxygen. So we call that air hunger. And so Ativan, even though we know it slows down respirations, it seems counterintuitive to use that, but it does kind of calm down the anxiety associated with that air hunger and struggling to breathe. So that's the most common one that I see used for anxiety or agitation and shortness of breath. And then for pain, we usually see non-tablet forms of medication, so not solid dosage forms. Liquid morphine, or Roxanol is its brand name, is usually the most common one that I see used in my setting, because there is some mucosal absorption, just like the liquid Ativan. It can be absorbed sublingually, and it's a very small volume of liquid that's actually needed. I think it's 20 milligrams per milliliter. So you could actually give a quarter of a milliliter, and that provides adequate pain control often. It doesn't last very long, so you have to give it about every hour or 2 hours. But that's a great product to use. But sometimes you also see some other options, like especially if giving something through the mouth is not ideal. So sometimes you'll see rectal suppositories use transdermal patches, especially if they can't, take medications orally. And then thirdly, I would say one of the major problems we see near, and I'm talking very near the end of life, is oral secretions can be excessive near the end of life, and that causes some choking or aspiration, coughing, and sometimes even drooling if they're breathing through their mouth. And so a lot of our hospice companies will use the atropine eye drops sublingually to kind of dry up saliva. And then they also typically order PRN suctioning of the mouth to get rid of some of those thick secretions that can trigger coughing, and just to kind of help keep the patient cleaned up, things like that.
I see that a lot as well. I also see I don't even know how to pronounce this.
Hyoscyamus.
Yes.
Yes.
So you can get a sublingual tablet, and I see that used a lot for secretions as well. But I'm with you. When it comes to my hospice patients, most of them are on liquid morphine, liquid lorazepam, some atropine or something for excess secretions, and then sometimes also liquid haloperidol. That's the most common medications I see used in hospice. That seems to be a good mix of medications that provide comfort. But when it comes to those medications, we know in our older adults using multiple CNS active medications at one time can cause some side effects, especially sedation, respiratory depression. How do you sort of balance out those side effects with the benefit of the medication?
Well, I think you really have to streamline therapy, and you want to make sure there's not a lot of duplication. So you may have a patient, and I'm just going to try to generalize and think of like a typical hospice patient who has been declining and maybe already was suffering from anxiety and agitation. And so they have an order on board for, let's say, alprazolam 4 times a day. And then they get put on hospice because they've had a decline. And we're going to add to it Ativan. So now we've got 2 benzodiazepines on board. That's where I like to cut out the duplications. If we're going to add the hospice medications, I'm all for it. But I want to cut out and taper off of anything that may be a duplication. And then I also want to look at, are there some opportunities to get rid of some other things? But it all has to really be personalized to the resident and kind of the status of the resident. When I first started consulting as a new consultant, when I thought someone was put on hospice, I thought they were going to pass within the next 72 hours. I thought that meant they are calling in the priest, we're reading last rites, but after 20 years of doing this, I've seen patients come off of hospice because they no longer met the qualifications. They were on hospice for 2.5 years, and they actually weren't at the end of life. They were just kind of going through a rough patch.
Oh, yeah.
And then you also see patients who don't make it through the night after the contract is signed. So everything is just so personalized. You really have to take it on a case-by-case basis to really look at those side effects and balance the risk versus benefit of the medication regimen on hand. I don't want to go through and just bushwhack everything that they're on just because we put them on hospice. I want to look at it on a case-by-case basis and make some recommendations, and kind of prioritize what are we trying to treat here? Are we trying to keep them calm because they're agitated? Are we trying to treat pain because they've got metastatic cancer and it's very painful and it's all over their body? Or are they just not responsive anymore and they're in a deep state of sleep? You just kind of have to prioritize.
It's a little bit different for each patient. It does seem like the hospice providers around here do try to start with lower doses of lorazepam and morphine, see how the patient does. If they're still in too much pain or too much shortness of breath, we'll increase it. But I think that's, their method of trying to figure out, okay, what is the lowest dose that's going to control their pain, make them comfortable, but yet keep them alert and have a good quality of life and able to visit with their family if they come, and then reassess. But of course, it comes down to what the patient wants.
Right.
Does the patient want to feel no pain and and is okay with being a little bit sedated? Or would the patient rather feel a little pain but be awake when their loved ones show up? So I think, it's a conversation with the patient. What are your goals? What matters to you? And then go from there.
Right. And hopefully we have that opportunity to be able to have that conversation with the patient. Sometimes they decline quickly and we're not able to have that conversation and we have to defer to the family or the sponsor. And, I really try to, I try to be available to make any suggestions that I can to be helpful. But a lot of times, like you said, the hospice companies kind of have their standard order list that they just go down and check the boxes of what they need.
You talked about patients being discharged off hospice. Sometimes, I'm sure you've seen this too, I'll have a patient go on hospice, we stop all their meds, and they brighten right up. I've had that happen a few times where they were, I believe, just suffering from polypharmacy.
Yes.
When we cut down on the meds, they feel a whole lot better.
Yeah, it's a testament to deprescribing and that
Mhm.
deprescribing works. You've got patients that are 90 plus years old in a skilled nursing facility, and they, throughout their life, have gone to see different specialists and different physicians, dentists, dermatologists, cardiologists, you name it. They have seen all sorts of different people for different ailments, and they feel like the appointment was a failure if they don't leave without a script in their hand. Or if they leave without a script in their hand, they feel like the appointment was a failure. And so over time, all these medications have been added to their daily regimen. And then they decline so much that they have to go into a skilled nursing facility, and we just continue all those medications without questioning it. So if you back off of some of those medications that might not be benefiting them,
Right.
then all of a sudden they perk back up and they're not even a hospice patient anymore because it was the medications that were bogging them down. So I'm a huge fan, and I'm always so encouraged when I see patients kind of bounce back just because we got rid of some things.
Love it. So when it comes to deprescribing, when a patient goes on hospice, looking at the medication list, they might be on all sorts of medications, a thyroid medication, blood pressure, statins, so many different medications. How do you decide, or how do you help with the decision making when it comes to what should we keep on board and what's appropriate to deprescribe at this time?
It absolutely has to do with the condition of the patient. And it's really just a balancing act of using some common sense, but customizing it to that patient and where they are in their hospice journey. I hate when people use that term, their journey, but it is kind of a journey in this situation. So like I said, sometimes you have patients who last for 72 hours on hospice. Sometimes you have patients who last for 2.5 years and come off of hospice. And then you have some who don't make it through the night, and then everywhere in between. So one of my favorite strategies to teach my students is how different hospice can look. Because like I said, I thought hospice meant we're at the end of life, call in the family, call in the priest. So one of my responsibilities as a consultant pharmacist in my facilities is to dispose of medications that are no longer in use. So whether the patient has deceased or the medication's been discontinued or the medication's expired. So we have to dispose of narcotics. And we also have to make sure that the records are in order and all doses are accounted for. And one of my favorite things to show my students is a very typical textbook hospice document, which is the patient who receives 2 doses of morphine and then passes peacefully. So morphine, as you know, comes in a 30 ml single, a single person bottle. And a lot of times you give a dose of 0.25 milliliters to a patient, and then maybe an hour or two later, another dose, and then the resident is deceased. And it's not that the morphine did that. It was just that that's what helped them peacefully take their last breaths and pass on. And so that's a very typical situation of hospice and giving hospice meds. But then there's also, in that same stack of documents that we're going through, we'll see a patient who got 37 doses of morphine. So everything is just so personalized. as unique as the hospice process of death and dying is, deprescribing is equally as unique. And just like you, deprescribing is a passion of mine across all areas of long-term care. And there's a huge opportunity at the end of life to deprescribe. And it really just means using common sense tailored to the individual at hand. And I really don't ever want to withhold medication that would be life-sustaining or just medication that someone needs to feel their best. But I don't want to burden them with medications that could be causing problems, or I don't want to be helping a situation that's no longer a priority. I'm not worried about their bone density. I'm not worried about giving them calcium plus vitamin D in their last 3 days of life. I'm not worried about statins. If you've made it to 92 years old and you're on a statin, I think the medication has done its job at that point. And, as thankful as I am for things like statins, they do tend to make you, they can cause some muscle pain. And I don't want to cause any pain in someone where pain is a priority. And even, this can be kind of a slippery slope, but some of those psychoactive meds that our patients are on, if they're on hospice and they are on morphine and Ativan and Haldol and atropine drops, they may not even be communicating with us. So if they're in a deep state of sleep, I don't think that they need their Zyprexa. Not to pick on Zyprexa, I'm just, pointing out that. But also one of the first things I look for, considering the setting of a nursing home, is, are we on dementia medications like Aricept and Namenda? Those medications are intended to slow down the process of dementia and maybe slow the progress of the disease down. They have already done their job at this point. And so those are two things that I like to take off as quickly as possible, just because it's no longer serving that patient. Medications like incontinence medications, the patient's probably already incontinent anyway. So those have a huge burden on that patient. They can cause a lot of problems, the anticholinergic properties of them. If we can get rid of those medications, they might be a little bit more alert and awake and able to possibly even eat and be a little more aware of their surroundings by taking those medications out of the medication cup for them. So I really just try to reduce that pill burden where I can. And, but there's some other things. From a personal standpoint, I went through hospice with my father-in-law back in 2019. And one of the things that kept him alive artificially that I did not know was a nasal cannula of oxygen. And we could not figure out why he was still hanging on. And of course, we didn't want to speed up the process in any way, but a lot of times hospice companies will order a nasal cannula of oxygen and, just maybe at 2 liters, not a high rate of oxygen, but it can be very uncomfortable to keep a nasal cannula of oxygen on. And he was always pulling at his oxygen. It bothered him and kind of agitated him a little bit. And when we finally gave him a break from that nasal cannula of oxygen, he slipped away. And we thought, and here I am, I work in this industry. No one told me that would keep someone alive artificially. He had not eaten in a couple of weeks. He had a few sips of water here and there, but it was the oxygen that was keeping him hanging on. And we thought, had we have known, we wouldn't have, because we knew it was so uncomfortable for him to keep on his face and he would pull at it. And he was trying to tell us, like, let me go. So yeah. We gave him a break from the oxygen because the hospice company came in to bathe him and shave him and, have him clean and presentable to the family. And when we took the oxygen off, that was when his sats dropped. And so I always try to tell that story because it's not common sense, but maybe don't keep certain orders going if they're no longer serving that patient very well. So,
right. Yeah, you bring up so many good points. At the end of life, are they having trouble swallowing? If they're having trouble swallowing, it's a good point to look at that and discontinue all the ones that aren't necessary. Of course, it's a conversation with the family and the caregiver and the patient to say, what do you want to keep on? What aligns with your goals right now for treatment? What doesn't align? And then there's a paper that came out called Deprescribing for People with Dementia, a Roadmap. And it came out July 2025. I really like it. It talks about deprescribing for patients with dementia, but in there's a tool that you can use for all patients. And it's from the University of California, San Diego. And they have a couple different calculators. One is a life expectancy calculator, but we know if our patient's on hospice that they're predicted to live 6 months or less.
Right.
So the other tool that's on the website is a time to benefit tool with medications. So, if a medication is going to take a year, 2 years, 8 years to benefit, what's the sense in putting the patient on it if they're on hospice? But with pain meds, we know that there's very small time to benefit, couple minutes, half hour, hour. So those are likely to benefit. But I think those tools are helpful to use for patients with dementia, and use those tools along with the treatment goals for the patients and caregiver. And it's pretty easy, after those conversations and using those tools to kind of decide what's going to benefit, what's not. I mean, even looking at diabetes treatment, of course, we don't want their blood sugar sky high, and we don't want them experiencing hypoglycemia. But other than that, we don't need to keep their A1C at a certain goal.
Exactly.
So it's just things like that eliminate a few pokes, maybe check a sugar once a day and see what's happening or whatever it might be. But we certainly don't need to burden the patient with that kind of thing. And with my grandma, too, when she was on hospice, they kept her on donepezil. And my goodness, did that medication make her nose run? And she would sit there all day with a tissue. And finally, I went to visit her and I'm like, what are we doing with the donepezil? She's already end of life. She doesn't recognize any of us. There's no benefit to it. And the poor lady is just sitting here wiping her nose constantly. Let's just stop it.
Exactly.
And so I think just even making families aware of these are the benefits, but these are the risks. And like you say with the incontinence meds, maybe the patient's not even able to get up out of bed anymore. And so what are we doing with an incontinence med? But it does take someone to look through the med list and go through each one to make an important decision of what should stay and what shouldn't. And if you don't have that conversation and just continue all of them, it's not really benefiting the patient.
And that's really where our fabulous nurses that are taking care of these patients really come in handy. I will have a conversation with the nurses and be like, do you really think that Mr. Smith still needs this? And they'll say, no, we have to crush the tablet. We have to put it in some pudding, and we're worried about him choking on the pudding. And sometimes we go back and there's still a little bit of the residue of the pudding in his mouth and we feel bad, so, there's so many opportunities, and our nurses that are taking care of these patients really can help us to personalize those recommendations. It is not uncommon for me to put those type of recommendations in my pharmacy report because I'm communicating directly with the director of nursing and the medical director who may not know those little nuances about, we have to crush the tablet up because he can't swallow a pill anymore. And the doctor doesn't know that that's what's going on. And so I can kind of bring them up to speed and say, are you sure you want to keep this on board? And they'll say, no, absolutely not. Let's discontinue that. So it's really just me being the vehicle, talking to the experts in the area and communicating it to their higher ups. And so I'm really just the vehicle, but I can initiate those conversations to help get rid of some things that are just a burden to the patient. And I really try to respect when the families are in the room. I try to reduce as many interruptions in the day of providing medical care as much as possible so that they can visit with everybody, they can have that time, and it not be so institutional and rigid with, now we've got to do blood sugars. Now we've got to give them an insulin injection. Now we need to do this wound care treatment and, have to do all this. Like, let's just keep the patients comfortable and let them spend time with their family.
That's right. I agree with you. And I agree that nursing staff, med aides, they have so much insight on patients and what's necessary, what's not. They're with these with these patients every day and might review their chart once a month. So they know more than I do about if a medication should be discontinued or not. So I have those conversations with the people who are with them every day to see how things are going.
Exactly. That's been my experience as well.
Well, thanks so much for this hospice discussion today. It's been wonderful. And it's so interesting to me to see how similar things are in Alabama and North Dakota and just all around. But it seems like things are pretty much the same when it comes to hospice care.
I thought about that when I was preparing for this. I thought, I wonder if it's just a regional thing that we use atropine eye drops in the mouth. Because I remember the first time I read an order, I thought, oh, they typed this wrong. They're not supposed to put eye drops in the mouth. And I asked somebody, I said, is this an error? Did they mean to type this? And they're like, yeah, that's what we do on hospice patients. I was like, oh, you give them eye drops in their mouth? So, yeah, it is interesting to know that they do it in other areas of the country as well. So,
yeah. Well, thanks everyone for listening. And I will put the Deprescribing for People with Dementia, a roadmap, in the show notes, and also a link to Carrie's LinkedIn. But if people want to find you and connect, is LinkedIn the best place to go?
That's a great place to find me.
All right, there you go. Go find Carrie, and everyone have a great rest of your day.